Thank you for coming out for our so early in the last day of the conference. Just a quick reminder that you guys probably know by now. Please do silence your cell phones. There's no photography allowed. And I would like to thank Spectrum Group for hosting this session this morning. We have Dr. Richard Ford here. And Dr. Richard Ford is an emeritus professor of medicine at the North Carolina State University. And he is a co-author of both the AHA Canine Vaccination Guidelines and the AAFP Feline Vaccination Guidelines. Today's presentation centers on using antibody titers in practice to assess immunity. And here's Dr. Richard Ford.
Well, I want you to know you have caught everybody off guard. We never in a million years, especially me, anticipated a crowd. The line is out the door and down the hall, still waiting for breakfast, which is a clear indication of your dedication to continuing education and free breakfast. So we're really glad that you're here this morning. I'm shocked to have this kind of a turnout at NAVC. I've been doing this a long time. This has to be some kind of a record I think we're setting. I'm glad you're here. Let me give you just a quick bit of background on what we're doing this morning. The title of the presentation, I think, was the Vital Vaccination Series, and in fact, what we are focused on this morning will deal with a publication, a copy of which you should have picked up on your way in, that I published as part of a series of articles on vaccines and vaccinations over a 2-year period in today's veterinary practice. And you can get this journal through NAVC. It is a free journal. It's actually quite a good journal as far as its educational format and layout, very applied information. But this is a topic that drew some attention, and that also kind of surprised me. But it turns out there are some changes going on that have influenced veterinarians' interest in doing antibody titers in practice. And that, combined with the fact that the technology has actually improved, has had a very interesting impact on how we're looking at these things, how we're assessing that. So my focus this morning is to look at how titers, how antibody titers, how the technology plays out in clinical practice. Now, as I begin this, I want to preface this talk. Since Spectrum Group invited me to make this presentation, there have been some new developments in veterinary medicine on a national and global basis that are adding emphasis to this. I'm not here to sell product, but I am here to show you what the technology is and the applications of that technology in clinical practice. And things are changing. I thought I'd preface by saying that, and then we'll kick this off. Let me, by way of background, give you a little insight on what's happened here. What I've got listed on this is kind of the nidus wherein all of this titer issue began to surface. Now, I've been writing AHA and AAFP vaccination guidelines since they began. Now, this is a group of people who, for no money, just time and energy, collectively put together the science and write recommendations on vaccination. Now, the science is there. We know this very clearly, that the vaccines that we are using for what we call the core vaccines, distemper parvoadeno for the dog, and panleuk, herpes, and caleci for the cat, we are all using excellent vaccines. This is not a manufacturer-specific thing. We've got excellent products. Well, the other thing that has emerged over the last decade is the fact that the duration of immunity is lasting quite a long period of time. We're looking at DOIs, durations of immunity, on these core vaccines of 7 years plus. And what have we been doing? What's our paradigm? Every dog, every cat gets every vaccine every year. And that has been challenged as we wrote the vaccination guidelines. And I want to tell you that there haven't been a lot of situations that I've been involved in where I lecture on a contentious issue, but this was one of them. I mean, quite honestly, when you get up in front of a group of veterinarians and say, hey, you don't need to give these vaccines every year, you can give them every 3 years. And they'll still be protected and well immunized. And that's when people actually threw food at me from the audience. That's happened. This didn't go down well. This was a bit of a bitter pill for the profession to follow. Now, I am still very much engaged in national and international vaccination guideline development. And I will tell you that in the United States, about, if you were to hold my feet to the fire, about half of the veterinarians recommend triennial vaccination. Another half still recommend annual. This is very geographically oriented in the United States. It is a much slower change than we anticipated. So we've been recommending triennial vaccine for core vaccines for some time, and it's just not happening rapidly. Now, the legal side is, and we've done this, the legal side is, and I want you all to leave here knowing this, that whether you are recommending annual vaccination for core vaccines or you are recommending triennial vaccines, the legal side is, with the exception of rabies, which is by law, you have discretion in the selection and use of vaccine. And in essence, what we're saying is that whether you are recommending annual vaccination or triennial vaccination, you are within the standard of care in veterinary medicine. There ain't nothing illegal about one or the other. Rabies is dictated by law. You must know the law. The client must comply with the law. So that's how that spells out. And that's really official. Now, all that comes out of the guidelines, but that spurred a lot of concern. And here's what happened. As we first recommended guidelines, and it still exists today, there is a body of us, a group of veterinarians, a fairly large number, that just don't believe it. The paradigm was annual vaccination. And it's the group that I call, I don't trust the guidelines group. And I'm not going to do that. So there's a stubborn group, if you will, that just won't do that. But there's something else that's driving the concern about triennial vaccination recommendations. And that is very interesting. It's a public health issue. And that developed at about 1998 when a physician, Dr. Andrew Wakefield, published in Lancet on the basis of 12 children that measles, mumps, rubella vaccine might actually cause autism spectrum disorders in children. Well, what happened is that parents became alerted globally, and they quit vaccinating their children. Today, have you heard this? We have an outbreak of measles, unlike we've had in 15 years in the United States. 600, just last week, the CDC reported 627 cases of measles in the U.S., the most since 2000. In the state of California today, there is an epidemic, an official epidemic of whooping cough, Bordetella pertussis. Well, these are vaccine-preventable diseases, and they are emerging in part, not exclusively, but in part because parents didn't want their children to be vaccinated for fear that the vaccines were going to cause concern. That has actually been conveyed to veterinary medicine. Clientele who are concerned about this are saying, I'm not sure I want my dog vaccinated. And wow, people are recommending every 3 years. And wow, maybe I don't want to put any vaccine into my dog. This is a very interesting thing. We are literally conflicted in our country now. Well, I don't want to risk injuring my child or my dog, and therefore I'm not going to get them vaccinated. But the risk is the break in the vaccine-preventable disease infections. I mean, we are seeing that. There is a concern out there today, and I'll bring that up too, in veterinary medicine as well as in human medicine. So this set the stage for, I want to do something else. What else can I do? And so if you look into immunology, we all grew up with Immunology 101 in veterinary school, and there is cell-mediated immunity, and there is humoral immunity when it comes to protection. Those are the two principal arms of the immune response. T cells, or cell-mediated immunity, is simply not easy to measure. It is cellular function. On the other hand, a product of the B cell is a protein, which we call immunoglobulin or antibody, and you can measure that. And so that has opened up an opportunity for us to actually study this. Now, this is a nice animation that captures humoral immune responses. Virus is in place. It has activated B cells. B cells now produce antibody, which are effectively able, with unique specificity, to identify those epitopes and attack and neutralize a virus and save the day. And the goal is to, wow, we can measure that antibody. And technology has brought us forward to the point where we can do it in practice, and we can do it efficiently. Now, when titers came on board, I got to give you a little history. I think this is relevant. Titers were applied toward the diagnostics, towards surveillance of infection, not in the individual dog or cat, but in the herd or the flock. And several companies had developed assays for use on the farm to survey a population at incredible risk. So they would take a few select animals, birds for example, and they would collect blood and they would sample them. And as they sampled them, they'd look for elevations in antibody. In other words, is something going through the herd or not? And they do this on like a weekly basis, and then all of a sudden, boom, red flag, means this flock is at risk. And that would give them a control tool to eliminate and exclude a section of the flock to save the remainder of it if a disease outbreak was imminent. And that's what antibody testing was done. Now, we are asking for more. We want to squeeze a little more out of this antibody thing. And we're looking at the individual patient now. So we would like to get that titer applied to numero uno, you know, my individual cat or dog. Now, this is asking a little more. We're raising the bar on antibody titers from herd surveillance, disease, infectious disease, diagnostic surveillance to individual animal. Well, the technology is keeping up with that, and it's now surfacing in veterinary medicine, and it's becoming readily available not only through commercial laboratories, but available as kits that you can use in practice. And the question has always been, how good are the kits? Do they work? What do they mean? That's what we're going to address. Now, let me take you back. One of the advantages of being old is that I've got slides. I can go back and pull out of my archives some interesting slides. This is actually a journal article, let's call it a magazine article, out of a famous, well-known magazine called American Baby. Now, if you were pregnant or planning to become pregnant, you would suddenly become a subscriber to American Baby. Now, this journal or magazine had in it a medical column, as well as advice on what kind of diapers to purchase and beds to buy and things like that. They always had a little medical thing. And I collected this one. So when my wife and I were pregnant with our son, she became a subscriber to American Baby. We were discussing heavily the role of who was taking out the cat litter at that time. And the issue of toxoplasmosis came up. And she read this article and she says, "You're taking out the cat litter, not me." Because in this article, Dr. Gauss here, who says very clearly that if you are pregnant or planning to become pregnant, have your cat tested for toxoplasmosis. Whoa! Nobody told veterinarians about this, because you're the one who's going to do the testing, right? So all of a sudden, this appears in this widely distributed magazine, and it's driving clientele to veterinary practices with cats to say, "I want my cat tested." This got very emotional. I'll never forget the day this lady was on the phone, called me at the veterinary school, client. She was in such distress, they said, "Dr. Ford, you need to talk to her." She was crying. I got on the phone and said, "What can I help you with?" And she says, "I'm pregnant and my cat sat on my chair." And I went, "Yes." Waiting for the rest of the story, I said, "What else?" And she said, "Well, that's it. My cat sat on my chair and I'm pregnant and I'm going to get toxoplasmosis." Her physician had so primed her with fear over toxoplasmosis, she was beside herself. I've lectured to medical associations talking about zoonoses. And as I do that, I asked the group of physicians in the room, quite a large group, what do you do with a patient who is pregnant and has a cat and is concerned? 50% of the group kill the cat. I said, "What in the world are you talking about?" And so you have to kind of get through this. There is considerable confusion over that. Well, now we've got an article saying test your cat. Well, some of you in this room perhaps remember a company that sold a test to you for use in practice. It's an old company. Anybody remember Pittman Moore? All right, goes back, yeah, a few of you do. Well, Pittman Moore had the Toxo test kit. That's a fascinating kit. I never actually used it, but I always wanted to, because the results appear not on a test platform, but in the eyes of the cat. They turn. So I always found that intriguing. But it is kind of interesting to see how that sort of thing unfolds. Here's a test kit. Wow, the test was positive. Oh my gosh. Oh my gosh. My cat's got toxo. Or does it? You know, that became the real issue. What does a positive test mean? What does a negative test mean? So that created a lot of confusion. All right, so we peel that onion back. And the reality is a lot of cats have antibody. And that's all we're doing is measuring the antibody. 30% of dogs have antibody to toxo, and 20% of people. So the antibody in this case is a reflection of what? Exposure. Exactly right. It is not a definition of infection. And we had to get over that. Now, our profession as a group looks at this, and we looked at these new antibody test kits as state-of-the-art opportunities. They got it or they don't got it. If you're positive, you got the disease. If you're negative, you don't got the disease. And that's not quite right. So shortly after we got into that paradigm, what happened was very interesting. And from what we expected to what the reality was a state of confusion. And by that, and this is reality, these tests might be positive, but falsely. They might be negative, but falsely. So what you are tasked to do today as a result of this is understand a very fundamental set of terms, one of which is specificity. What is the specificity of this little laboratory test? In other words, do I have false positives? Notice how I've written this. This is for you. This is to help you, like it helped me, remember when I'm reading the literature what sensitivity specificity means. The capital P in here, in specificity, refers to a false positive rate. High specificity, low numbers of false positives. High sensitivity, negative, get it? Low numbers of false negatives. So we're looking for tests that have been assessed for sensitivity and specificity. We want to narrow the gap on the false positives and false negatives. We've got tests that you can buy today, high-end PCR tests that literally have such bad sensitivity specificity, you could pull a quarter out of your pocket and flip a coin and make the correct decision, or as good as the test. And you're buying those. So it is important. It is important for the veterinarian who's utilizing this kind of technology, whether it be in hospital, point of care, or sent out to the laboratory, to actually have a concept of what sensitivity, specificity means to you with respect to the test itself. So that's been a huge issue in the introduction of new technologies. So antibody titers. The question at hand for all of us now that the technology is there, we can measure antibody. What does it mean? What's the real significance of it? All right. Now, all of you should have a copy of this manuscript, this article that I wrote in Today's Veterinary Practice. And in that article, I've used this little acronym that I find helpful. In this, we're looking at antibody titer at the 30,000 foot view. For just a minute, bear with me. And I use pi, because antibody titers don't all mean the same thing. And it's very important to grasp that. This is where I start when I'm looking at a new titer test, is PIE. The test, the antibody, is reflective of protection. That's kind of where we're going with vaccines, isn't it? We want to look at that element of it. But it could also mean the patient is infected, depending on the test, depending on the antigen. And it could also be limited to just exposure, which is independent of infection. Now, I want to give you some examples of this. Let's take infection first. I want to give you a sample. This is a SNAP test from a cat. And the cat has a positive antibody test for FIV. So the interpretation is that cat's what? What does that mean? Infected or? Well, it actually is a test indicator. If a cat has antibody to FIV, they are infected. Notice on the other side, this is a combo test, that the FELV antigen test, you can get antigen and antibody on the same platform, is actually negative. So we got a cat that's FIV positive. What's the sensitivity of and specificity of that? So I'm really interested in this because I know that the specificity of this may be compromised if I don't know the vaccination history of the cat, right? This is really important. We know today that all of the FIV vaccines, the vaccine will cause a false positive on all of the commercial FIV tests. So if I don't know the vaccination history on that cat, the sensitivity, specificity in this case, really goes downhill for me. I can't relate to that test unless I know the vaccination history. So that's a big issue in that respect. But this is the SNAP test is a good example in FELUC FIV as a good test for diagnostics for infection. Then there's the exposure side of the equation. This animal, this is another SNAP platform that's very prevalently used. This animal is positive for Ehrlichia canis. Now we see that a lot, and I see a lot of misconception on a positive Ehrlichia canis. Well, they've got it, so I've got to give them doxycycline. And that's not true. The SNAP test for Ehrlichia canis antibody reflects exposure. It does not define infection. It's still your responsibility to develop a diagnosis based on other laboratory parameters, total protein, looking at the platelet counts, looking at hematology. And there are other parameters that must play into a positive for exposure versus positive infected. And that's part of the game that we play. Now, there's another very important one. You can do antibody titers on dogs for rabies. And those of you who have done them, send them to Kansas State University for a fluorescent antibody virus neutralization. This is an in-laboratory. You cannot do this in your practice, obviously. And this is a test that says the dog has a titer for rabies. What does that titer mean? That titer cannot legally be used as an index of immunity. By law, in every state in the United States, a positive for rabies titer is not reflective of immunity nor protection. All it means is for exportation to rabies-free countries and regions of the world, this dog or cat that has a positive FAVN test has been vaccinated. That is all that means, and it only has relevance to the importing country. So you can do a titer, but you've got to understand, this is not exposure to the virus, this is exposure to the vaccine in this case. So this, you see how this thing begins to unfold, and it gets a little more complicated as you begin to understand that antibody, there's a lot of antibody generated, but it really, you have to understand what it's being applied to in order to interpret the significance of that. Now, talk about the protected side of the PIE. This is relevant to vaccines. This is new. And in the last, I'd say probably almost 10 years, these tests have been evolving in veterinary medicine. There are two of them now. The VacciCheck test is the one that's represented here today through the Spectrum Group and distributed through them. Then there's also TiterCheck, which is a symbiotics product. And VacciCheck, which is developed out of Israel by Biogal, has an interesting, we've been watching this for some time now, allows you to do point-of-care testing for antibody for the cat and the dog. That's somewhat novel. And you can obtain quickly in your practice titers for distemper, parvo, adenovirus, panleuk, herpes, and calesi. The results are reported in a semi-quantitative way. In other words, you get a high positive, low positive, and negatives. And so they give you this spectrum of range of positivity as well as negatives. The TiterCheck, the other, excuse me, the other in-house point-of-care test that's available is canine only for distemper and parvovirus. And this test provides qualitative assessment in the result reporting, which is you got it or you don't have antibody, plus minus. So that's what's on the market today. We've been looking at these, and I will tell you that independently, various universities outside and inside the United States have looked at these assays and tried to assess the sensitivity, specificity of these tests and have published that. And what's impressive is that they are high. We're doing a good job. These tests must be collaborated or corroborated with the so-called reference standard. Some people call it the gold standard test. Its hemagglutination inhibition is the gold standard test for parvo. Virus neutralization for distemper, that's the go-to test. These are laboratory-based tests. But how well do the point-of-care tests compare to that? Turns out quite well, especially for parvo, or feline panleukopenia, and distemper. It does a pretty good job for feline calesi virus as well, which is interesting. For herpes virus, the sensitivity specificity falls off because cats don't generate large amounts of antibody to herpes virus. So the you got it, you don't got it is a very, very narrow range, and we're not comfortable yet making hard decisions on a herpes virus antibody titer. If they've got a really high titer, then it's real. But a lot of times the titer generated by the cat is just so low, it's very hard to interpret those. But we do have a lot of advantage with regard to feline, canine parvo, and canine distemper with point-of-care testing. Now, here's the way we look at it. What's the specificity of these tests? It's good. So with regard to canine distemper, vaccinated dog, canine parvo, feline parvo that has a positive test, I'm going to tell you that cat or the dog is protected. It is a good test. There's always going to be some false positivity, but it's relatively low. So we've got a good idea. Cat got vaccinated, dog got vaccinated, the test is positive. You can generally assume there is a very, very good association between a positive titer and protective immunity with distemper and parvovirus. Very good. Now, what if it's negative? All right, the test is negative. What does that say to you? You're in practice, you got a cat or a dog that's been vaccinated for distemper parvo adeno, and the parvo is negative. What does that mean? Okay, doesn't have antibody, doesn't have measurable antibody, right? So how would you interpret that test result? You would say the dog is susceptible, wouldn't you? Or is it? All right, now this is where you have to use the gray matter. This is where the clinician has to say, well, is this a puppy or an adult dog? In a recently vaccinated young dog, just completed the initial series, this is a critical issue. And the fact is that if the dog or cat is young, has just completed the initial series, the first 3 doses, and the test is positive, they are protected. If the test is negative, they are susceptible. They have not seroconverted. That's a cat or a dog that is at risk of infection. Now, that's the young dog. Let's take the old dog. Dog hadn't been vaccinated, or we found this dog. Rolls in, he's somewhere between 4 and 7 years old, you estimate. We have no idea what or if he's ever been vaccinated. You draw blood, he's got a positive titer. He's protected. He's protected. The other issue is, what if it's negative? Is he susceptible? Not necessarily. An adult dog or cat that has no antibody may not be susceptible. And the reason is they have memory. Now, I'm going to go back to this just a second. I'd like you to remind you of this. This is the antibody response. A virus has invaded or a vaccine has been inoculated. The response is activation of B cells and the production of antibody. Okay, I showed you that earlier. Antibody is what? It's a protein. It goes away with time if there's no stimulation or provocation or boostering. What doesn't go away, and what we sometimes forget, is the blue B cell. That is B cell memory. Those things stick around for a long time. Even though antibody falls off. We've done this in dogs 15 years old, have never been, haven't been vaccinated in 9 years. Challenged them with parvovirus. Challenged them with virulent virus. And what do? Oh, I remember that. And they boost very quickly, literally within hours. Their titers begin to go up. So that's that immunologic memory. And the titer test gives you an opportunity to interpret what's going on if you understand the terms under which we're playing the game. So it's an interesting concept, but it gives us a tool. Now let's apply that tool. Antibody titers versus vaccination. What are the in-practice applications of the technology today? This, I think, is very important and highly relevant to what we're doing. I want to take you through a few examples of how you might apply in-house point-of-care antibody testing. Very important point. We know, I think you do too, the number one reason for vaccination failure is maternal antibody. No question. Well established. The purple line on this graph represents the antibody titer in a puppy that has nursed. Within 3 days, this young dog will acquire almost all of mom's immunity. And that gradually falls off. Well, this immunity is protective, right? That's to get them through the rough times. And mom passes that along. So whatever mom has is going to be reflected in a puppy, assuming the puppy nurses well in the first 3 days of life. This is colostrum. This is not milk. So we know also that if we administer a vaccine at 8 weeks of age, which is commonly recommended, the vaccine will be interfered with by maternal antibody, and there will be no immunity. A point I made yesterday in the seminar, and I want to reiterate that today, is that you must leave here knowing that vaccination does not equal immunization. Very important point, very fundamental, sometimes hard to communicate to the client who takes that, oh, I got the shot and we're off to PetSmart. Not necessarily a good idea. So this dog is not immunized. What we have found with the high-titered vaccines that you are all using today is the mom titers are higher, and it is neutralizing or interfering later in life. And we are now recommending absolutely, and you should all be doing, a third dose out here around 16 weeks to ensure that we get immunity. But do we? We are concerned, ladies and gentlemen, this is a point you got to leave here with. In several locations in the United States, we have been collecting information for about 2-3 years now on this, that apparently some of these dogs out here have enough parvovirus maternal antibody to neutralize vaccine virus later and later and later. And we don't know in these patients whether it's moving out this way or they're actually responding to that dose at 16 weeks of age. This is something that is evolving. Keep your ear to the wall on this. But I want to remind you all that there is a threshold here. That yellow line that I just drew is the level, the threshold of protective immunity. So antibody, maternal antibody above that line will protect against distemper, parvo, and adenovirus. And the vaccine-induced antibody above the line will protect against distemper, parvo, antibody, as long as they responded to the vaccine. But if they did this, we don't know. So what we've got here is this big window of susceptibility. This is the don't go to PetSmart yet window. Because the dog, we know, very important point, very low, we don't know how low, very low concentrations of maternal antibody can interfere with vaccine below the protective threshold. So the dog has interfering amounts of antibody, but not protective amounts of antibody. So this is a big window of susceptibility here. And in some dogs it can last 7, 8, even as long as 10 weeks. And the question is, what happened after vaccination? I want you to know that one of the principal applications of point-of-care testing for antibody is to look at this here. About 2 to 4 weeks after the last dose of vaccine, in a patient that you feel might have risk for exposure, or the client is concerned, then you should do that. If the test is negative, This dog should be revaccinated. Parvovirus is critical. We are concerned. We have a lot of so-called breaks in parvovirus. So if they are negative 2 to 4 weeks later, at this point, you're out around 20 weeks, we would absolutely advocate a booster dose at that point. Very, very important concept in the application of this. Now, there's another reason vaccines fail. As I give vaccine lectures, veterinarians say, well, what's your protocol for Dobermans and Rottweilers? You know why? A lot of us remember when parvo hit in the early 80s, late 70s, and this is a new virus, went around the world, and we frantically put together vaccines. We're using feline panleukopenia vaccines to vaccinate dogs. Desperate. Dogs were dying right and left. And we finally got canine parvovirus vaccines, and the problem was solved. Except for select lines of Dobermans and Rottweilers who were well vaccinated but broke with parvo. Well, do we see that today? Now, the fact is we don't. Not in Dobermans and Rottweilers. Not to the extent we did then, but I will tell you this. We are seeing certain breeds, lines within breeds, that are not responding to parvo vaccine. We thought, well, we can fix that. We'll give them more vaccine. Turns out, these pit bulls, does that sound familiar to some of you? We are seeing a number of breeds that selectively seem not to respond well to vaccine. American Pit Bull is really at the top of that list. This is all anecdotal. We just don't have the data on it. But the fact is, these animals appear to be genetically programmed not to respond. These are so-called genetic non-responders. Giving them more vaccine will not drive immunity. So you're simply not able to get there with that one. So with canine parvovirus, we've got an estimated about 1 in 1,000 dogs. This is what we preach through the guidelines. And about 1 in 5,000 dogs, much lower number, are genetic non-responders to canine distemper. This is where I think you have the opportunity to provide a better insight on your patient. Did it respond or did it not respond by doing the post-vaccination titer? This will be reflected in the next iteration of the vaccine guidelines. So it is an opportunity to do assessment. If they are a genetic non-responder, they're not going to make antibody. And you can see that. You must understand they are susceptible. Another opportunity is the dog or the cat, puppy or kitten that presents to you with an unknown history. This, I think, is also a valuable tool, particularly where they might be introduced into a population with other pets. And you can tell quickly whether or not they have been vaccinated or exposed because they've responded with an antibody to the exposure or to vaccination. But it gives you an idea as to whether or not they are protected. And that's the leverage that we have that we didn't have earlier. Quick assessment of whether or not they're protected in an orphan puppy, orphan kitten, or one that just shows up on your doorstep. Another application that I think has become important, in the AHA vaccine guidelines, we have made it very clear in a section that I developed for the guidelines on vaccine adverse events. We are concerned about dogs that do develop autoimmune disease, hemolytic anemia, thrombocytopenia, and the impact that vaccination might have on reactivating this. We're talking about the Cocker Spaniel that you treated last year for hemolytic anemia, and he's back for vaccinations. I'd suggest you might not want to vaccinate that dog, for the concern that the vaccine, which is a pretty potent immunologic stimulation to that animal, may reactivate thrombocytopenia or hemolytic anemia. We have very little data on this, but the fact is those are the recommendations. And we have published, we don't recommend vaccinating the dog. What we do recommend is do a titer. At least you know then they have made antibody. So what is the titer telling you in this patient? The memory is there. Next year, the titer may go away, but the memory is there. I've got that documented. That's very important. And just pulled this off. This is a January 2015 article out of the Bellingham Herald in Nevada, in an area where we have been dealing with parvovirus outbreaks. A shelter is shutting down because they've had, 11 cases of canine, parvovirus in this case. We are seeing a lot of this. We are also seeing the horrific mistake of shelters saying, well, we need to depopulate, let's kill them all. Totally unnecessary to do. What we are suggesting is that in these high-density populations where the risk of exposure is good, that for rapid assessment of dogs and cats coming into the facility is an opportunity to say, this one's protected, it can go into this group. This one is not, it needs to go into this area of the facility. And mitigate the risk of exposure. Another side of this that has become very, very important and very applicable is in outbreak management. Shelters are understaffed, underpaid, and underloved. And I'll tell you, they're facing some real obstacles. They don't prevent infectious disease. All they can do, if you've ever done shelter medicine, is manage infectious disease. Point of care antibody testing is a critical value for that shelter that I showed you in Nevada. In other words, to go in and do the assessments. Well, these animals all have a positive titer for parvovirus. We don't need to euthanize them. They're safe. Leave them where they are. We don't need to isolate them. They've got immunity. Now, these two over here don't have antibody. They are susceptible, and they're the at-risk population. Let's segregate those and try and mitigate the disease in them. But this business of going in and mass killing all of the animals, depopulating the shelter because we think they're all going to get parvo or distemper is totally unnecessary. So the whole theme of things is changing. You have some tools now available to you that we've not had before for point-of-care testing. They are applicable, and from the testing that has been done independently of the companies, looks like this is a valuable tool. It has high sensitivity, high specificity, allowing you to make these kinds of decisions in practice at the appropriate time, at the appropriate fee. So that's kind of a quick and dirty. I think the manuscript that you should have picked up will give you some more details on each of these applications, but I hope that gives you a little bit of insight on how to use that. So ladies and gentlemen, thank you very much. I'll take questions up at the front, but thank you so much for coming this morning.